School of Social Work does have a continuing education program, and they have a lot of course offerings. I think that is one option. The New Jersey Prevention Network is another one. They are mostly for DMHS licensed folk, but if their classes aren't full, I think sometimes they'll let other people in as well. And I believe Stockton University has also started a continuing education program. So those are all options that you guys can think about. The certification board also offers some classes. I'm not sure how many, but you can definitely check those out. Okay, so you guys are all currently on mute. We're going to keep you on mute to cut down on any background noise, but we do know that Dr. Tobia is very informal, so anytime you have a comment or question, definitely you can go ahead and unmute to ask that. So most of you have your full name on the screen. That's great. That helps us accurately take attendance, and we appreciate that. If you need public health CEs, please let us know that by putting that in the chat. All the CEs come automatically on the certificate. There's just an extra step for public health, so we need to know that you need them. So this is our busy week for wrapping up. Tomorrow we have the 3-hour mandatory ethical and legal class from 1 to 4. So if you haven't taken that, that's mandatory, this renewal cycle for your CADC or LCADC. Definitely jump into that. And then Friday we have compassion in psychotherapy. So we do have some scholarships available through the Division of Mental Health and Addiction Services. We like to give them out, so please apply if you are eligible. And today you are here to learn more about anxiety disorders with Dr. Anthony Tobia. Having trained in a dual residency in internal medicine and psychiatry at the West Virginia University, Dr. Tobia currently holds titles of Professor of Psychiatry and Clinical Professor of Internal Medicine at Rutgers Robert Wood Johnson Medical School. Dr. Tobia has dual appointments in the Division of General Internal Medicine and the Department of Psychiatry, where he serves as the interim chair. Dr. Tobia is also certified by the Board of Psychosomatic Medicine and is currently the Service Chief of Psychiatry at Robert Wood Johnson Barnabas Health in New Brunswick, New Jersey. Dr. Tobia's academic interests include various innovative teaching approaches, including 6 that are registered in the Office of Research Commercialization at Rutgers University. He has seen more films than anyone I know, and he uses his knowledge base to interpret them in interesting and unexpected ways. So I'm so glad that you guys are all here, and you're going to have a really interesting day. I'll turn things over to you, Anthony.
Thanks, Noelle. So welcome, everyone. We're going to run this seminar very similar to the way we've scheduled things multiple times in the past. We'll take breaks pretty much on the hour, and then at or around 11:45 or so, we'll take a break and then begin the film at around noon, maybe a little before. We'll see how it goes. Come back, we'll kind of process parts of the film, especially in light of the information presented in the morning, with some basic knowledge, building blocks provided. Now that you've seen a fictional case, where might that take us to use Peter Benchley's JAWS in reviewing today's topic, which are the anxiety spectrum disorders. So that's the basic format. It'll bring us right up to 3 o'clock. Now, one quick bit of disclosure. The handout that you have is comprehensive, and it's intended not to be fully reviewed. So when we fall short of that final slide, please know that is by plan. That's something that I thought through and thought that it would be better to give you the comprehensive document with the knowledge that we're not going to get through it than to try to shorten it and fit it to be completed within or by 3 o'clock. The other part of it too, since this is the last time I'll be seeing you in this venue, is that if there is information or slides that we don't get to, and again, that's by design, maybe I could use it as a teaser to keep in touch and maybe develop something, maybe even at one of the other venues that Noelle just gave us. So we'll see how that goes.
I missed what happens at Rutgers isn't doing this anymore, or when you say another venue?
Right, Noelle, do you want to mention?
So the Center of Alcohol and Substance Use Studies is closing its professional development seminar series. But Rutgers University School of Social Work does have continuing education, and University Behavioral Healthcare also has some, and then there's some other places. But yeah, our particular series is ending this month.
Okay. Anthony, would you be able to present through the social work school, or you prefer not to?
Yes, I think that would be the low-hanging fruit. I don't know exactly who I would reach out to, but we could figure that out, especially if some of the folks who are in attendance today keep in touch with me. Maybe we could form a group and reach out to the School of Social Work. That I think would be an easy option.
I can send you a contact for there.
That sounds awesome. We're already on the way.
Absolutely.
Right?
And you mentioned
Thank you.
handouts. I don't have any handouts.
I emailed them this morning, but I can resend it to you, Joyce.
Oh, you sent it this
Okay,
morning because I
thank you.
didn't get them either, but I didn't look this morning. Okay, thanks.
So I was apologizing for something that you don't even have yet. That's good. My apology still stands in terms of the comprehensive
Okay.
nature. Before I share my screen, any other questions we could address?
This is just a survey at the end, correct?
Yep.
Yep.
All right. So let's do this. Could everybody see the screen okay?
Yep.
Yes.
Good.
Yes.
All right, we're good.
Yes,
Wonderful. We're good to go. So I'm often asked what my favorite movie is, and it's really hard to answer that, by the way. I think it is Kill Bill, but it's really hard to answer that without taking into account how psychologically rich the film is. And if you look particularly at the horror genre, this film and Kubrick's The Shining probably are number 1 and 1B on my list. So I do apologize for any confusion. I had asked both Ricky and Noel to switch around the schedule so that Jaws could be discussed today. I did want to make it our final presentation because of not only it being the summer or near the summer, but also being one of my top 2 films to discuss psychological theory and even pathology through this film used as a fictional case. Many of you will recognize this. This is a screenshot taken from the 2012 film, Joss Whedon's The Cabin in the Woods. If you look in back of one of the directors or co-directors there in that short sleeve white shirt, you see a list of Whedon's vision of the top monsters in our American culture. And for each of these, I have created a didactic. So we could actually use this board as a syllabus for a course, and at the medical school, we do just that. Today, really, the focus will be on the lower right, Giant. We'll get to Peter Benchley's brainchild, this giant 25-foot great white shark. There will be other characters taken from this particular slide, including aliens, as well as others. But the real focus today is the role of the giant in horror and the way we use this particular horror film titled Jaws to teach the anxiety spectrum disorders. Not much to do here. This is a reminder that we have tons of supplements that are posted internally, one of which is a recording or plural recordings of yet another didactic where we discuss very similar topics, but through the situational comedy Seinfeld. And often there is a Seinfeld episode or episodes that talk about, in this case, the anxiety disorders that can be used as a complement to today's discussion. Here are our listed objectives. Number 1, we will recognize that a condition called generalized anxiety disorder has specific criteria. Often this condition is a misnomer. People just think that if individuals are suffering from generalized anxiety that is affecting their lives, they have this condition called generalized anxiety disorder. That is not true. We're going to get into that today. We're going to identify the major features of this condition, generalized anxiety disorder, that overlap with major depression. We're going to state how cause and effect is established within the definition of an adjustment disorder. We're going to define the cutoff that differentiates acute stress from post-traumatic stress disorder. And then finally, we're going to list a differential diagnosis for a patient who presents with avoidance behavior, and then look at a feature of each of these conditions to help differentiate from the rest. Previously, that is the DSM-4, we looked at the anxiety disorders as a single chapter, and with revision to the DSM-5, which was published in 2013, we see that the anxiety disorders have since been reclassified into 3 distinct chapters, the titles of which you see here at Roman numeral 1, 2, and 3. For all of the above, for each of those Roman numerals, what causes anxiety and therefore what causes the anxiety disorders are biopsychosocial. And we could say that quite confidently because every behavior, whether adaptive or maladaptive, are caused and influenced by biopsychosocial factors. With regard to the anxiety spectrum disorders, biological factors include a chemical imbalance. The chemicals are called neurotransmitters, and this imbalance or disequilibrium focuses on 2 of these neurotransmitters. One is serotonin, that's abbreviated 5-HT, and the other is norepinephrine, which is adrenaline, and that's NE. These are the same neurotransmitters that underlie the depressive disorders. This is further confirmed when we see that somatic treatments, aka medications, that the mechanisms of which we understand, how they correct chemical imbalances of norepinephrine and serotonin, alleviate the signs of anxiety. And because those neurotransmitters are central, the same neurotransmitters for depression, we know that these same medications improve the depressive disorders as well. We'll get into a little bit of psychological theory today, that is theories behind why individuals become anxious. And then, of course, social factors also play a role. An easy example here is that there is a social precipitant or trigger that might result in the precipitation of an adjustment disorder. We'll get into that and the definition of an adjustment disorder in a little bit. I want to talk a little bit more about psychological theory. Don't pay attention to the top left. That's only a reminder to me that we have a supplemental document that has been made to support information on this slide posted internally. One of the original definitions of anxiety comes from Sigmund Freud. And Freud believed that anxiety was intrapsychic. That is, it was an internal conflict of the organism, of the person. More specifically, it was a subconscious conflict between what we want to do, our id, and what we are allowed to do, our superego. These are 2 equal and opposite parts of our subconscious. These are 2 equal and opposite parts of our personality. And because they will never agree, because they will never be in sync, there's always friction. And Freud called this friction anxiety. The third and final part of the Freudian subconscious is called the ego. And the primary role of the ego would be to dissipate or alleviate the anxiety caused by the friction between one's id and one's superego. So that's a ultra quick primer on Sigmund Freud and what causes anxiety. And with a malfunctioning or fractured ego, with someone with low ego strength, what may cause an anxiety disorder. For instance, and we're going to discuss specifics pertaining to the three characters in the film Jaws, the way in which the ego actually alleviates anxiety are through subconscious mechanisms called defense mechanisms. When these defense mechanisms, when these subconscious processes are functioning, and an individual is flexible in using a defense in this situation and another defense in yet another situation, well, that ego strength, the functional use, the adaptive use of the ego defense mechanisms will alleviate the anxiety. On the other hand, when one's defense structure is rigid, when they use a single defense, and when that defense becomes maladaptive, it will begin to malfunction, and therefore it will not alleviate anxiety, and that individual is at extremely high risk for developing an anxiety disorder, right? So, and we'll talk about some examples of defense mechanisms pertaining to Sheriff Brody, Matt Hooper, as well as Captain Quint. A contemporary of Freud, Carl Gustav Jung, took Freudian theory and put his own fingerprints on it. What Jung looked at was the collective unconscious. So he agreed with Freud that we all have a personal unconscious, but he expanded that to include another aspect of one's unconscious and called it the collective unconscious. The collective unconscious has different components, and these components are called archetypes. There are both major and minor archetypes, and without getting into Jungian theory in too much detail, there is one major archetype I just wanted to mention today, and that's the shadow. The shadow is somewhat analogous to the Freudian id. The shadow is that part of ourselves that is primal, is animalistic, and needs to work in concert with other parts of the collective unconscious per Jung. So the analogy of the id and the shadow are such that we can now apply these concepts to Fidela. Right? So who is Fidela? Well, and I'll certainly mention this more than once. The movie you are about to watch is a remake. Not only is it adapted from a book, but it's actually a remake of Moby Dick. We see a lot of similarities between Melville's novella and Benchley's book adapted to film in 1975. So when discussing Jaws, I often discuss that novel on which Jaws is based, and that is Herman Melville's Moby Dick. Fidela is the harpooner on Captain Ahab's boat. What's interesting is that at the time when the Pequod sets sail, Fidela is hidden below deck, analogous to the subconscious. He emerges later in the story to the surprise and at some point even horror of the crew. This is very metaphorical. This is very symbolic. Fidela is the symbolism, is the metaphor of anxiety. That which is below the surface, but then comes through to the conscious awareness of others. That's exactly what this character does, how this character is introduced in Moby Dick, and is a wonderful analogy, not only for anxiety, but anxiety via the psychological theory of both Freud and Jung. Just to support Fidela as Jungian, Herman Melville himself refers to this character as Ahab's dark shadow. So unbeknownst to Melville, he actually uses a clinical term, shadow, coined by Jung. Shadow is that archetype. It's that part of our unconscious that harbors our primal needs and our primal impulses, and therefore is analogous to the Freudian id. With that as a brief background, biological, psychological factors contributing to anxiety, let's now begin to review the different anxiety disorders, and we'll do this according to the 3 separate mini chapters published in the DSM-5. The first group are the obsessive compulsive and related disorders. The acronym to remember these conditions is BEFORE. From here, we will review the anxiety disorders proper. And then following that third and final mini chapter are titled the trauma and stressor related disorders. And the acronym to remember those conditions is the word AFTER. So we have BEFORE, then we have the anxiety disorders proper, followed by AFTER. I want to take a couple of minutes to review this slide. What you're looking at here is the progression of an abnormal thought. So when we provide a mental status exam, which is a routine part of the neurologic examination in medicine, one component of this mental status exam is thought or thought content. Many of us, I think, would instantly jump to the idea, pardon the pun, of a suicidal thought as perhaps being an example of an abnormality within that component, within that rubric of thought content, and you'd be right. But there are other examples as well listed on the right side of your slide, beginning with the overvalued idea. Overvalued idea, by definition, does not result in clinically significant distress or impairment. We are all prone to overvalued ideas. Sometimes people may refer to these as superstitions. In the context of what we're talking about, in the context of a mental status examination, overvalued ideas should not, that is, superstitions, should not adversely impact our functioning. When they do, in clinical medicine and clinical circles, we usually change the name. And one of the names we may use to now describe this abnormal thought that is now impairing is a preoccupation. Before I get into that, I want to skip all the way down towards the bottom of that blue outline box on the right side of your screen and discuss the delusion, because what you've seen that I've done is divided the delusion from all of the other examples of intrusive and persistent thoughts. What differentiates the delusion from everything else is twofold. Number one, by definition, a delusion is an abnormal thought that A, is not reality-based, and B, is rigid despite the individual being provided information to the contrary. Again, let's go through this again. Like every other clinical label listed in that box, the delusion is an abnormal thought. However, what differentiates it from all of the above, that is everything above that green line, is A, it is not reality-based, and B, it persists with rigidity, despite the individual being presented with evidence to the contrary. When an individual meets those two components, those two traits applied to their abnormal thought, that abnormal thought is called a delusion. So if you look at the continuum that we're starting to build on the right side of your screen, you have the mildest form of abnormal thought called an overvalued idea. By definition, it's mild, meaning that it does not impair clinical functioning. Everything else in that list does. What differentiates the delusion from everything else is that not only does it impair clinical functioning, but it is not reality-based, and the individual is rigid in their belief, despite being provided evidence to the contrary. So those are the two poles that serve as the continuum of intrusive and persistent thoughts. There are several terms used for abnormal thoughts of intermediate severity. Those include preoccupation, rumination, and obsession. And that's how we actually populate those bullets 2, 3, and 4 on the right side of your slide. Before we begin to talk about each of these, I do want to make one comment, and then I want to ask anyone who has any questions to unmute, because this might be a little bit of a difficult topic, especially upon the first time hearing it. So first, my comment. For all intents and purposes, those intermediate terms, specifically preoccupation, rumination, and obsession, are interchangeable. If you evaluated a client or patient, and if you presented that individual at a conference to a supervisor and said that their mental status exam was significant for several preoccupations, if your supervisor stopped you and said, "I'm sorry, but these are really ruminations," the fact is that we're talking about a situation now where someone's being a little nitpicky. For all intents and purposes, preoccupation, rumination, and obsession are terms that are interchangeable. Now, are there nuances? Sure. But in clinical practice, those intermediate terms are interchangeable. With that comment, we're going to go to the next slide. But before I do, I want to make sure that there are no questions focused on this slide. Good. All right. Well, then let's click on preoccupation, see where we go. Well, there are 3 conditions published in the DSM defined through clinically significant preoccupations, one of which you are looking at right here. When an individual has a clinically significant preoccupation with one or more perceived defects in their physical appearance, they have a condition called body dysmorphic disorder. Preoccupation with one or more perceived defects in physical appearance is the hallmark for body dysmorphic disorder. Let's say that the individual presents to you the preoccupation, but instead of their focus, instead of their being preoccupied with a perceived defect in appearance, they are instead preoccupied with having or getting a serious illness. In that case, your single best answer is not likely to be body dysmorphic disorder, but what? Anybody have a guess as to what that condition is?
Is it
Hypochondria?
Psychosomatic disorder.
psychosomatic? Yeah.
Yeah, so you're all right. It is a psychosomatic disorder formerly called hypochondriasis. As of 2013, that is, as of the publication of the DSM-5, hypochondriasis had its name changed to illness anxiety disorder. So illness anxiety disorder and body dysmorphic disorder are 2 of the 3 medical conditions or psychiatric illnesses that are defined through a maladaptive preoccupation. One is focused on a perceived defect in appearance, and the other with having or acquiring a serious illness. The third and final condition in which an individual may present with clinically significant preoccupations is an eating disorder, where the preoccupation is not with a defect in physical appearance, it's not with having or acquiring a serious illness, but instead body image. Right? So depending on what the focus is, you could have any one of 3 conditions in psychiatry: body dysmorphic disorder, illness anxiety disorder, and an eating disorder. Of course, for illness anxiety disorder and eating disorder, they are not contained within the anxiety disorder chapters, but body dysmorphic disorder is. By the way, if you follow on the bottom left of your slide, we will follow that acronym, in this case, before, spelled B-F-O-R-E, lighting up in sync with the top of your title slide. That is the title at the top of the slide, B for body dysmorphic disorder. Some specifiers: you may have muscle dysmorphia, where that specific defect in appearance is body build being too small. And then other specifiers with regard to the severity of one's insight: good, poor, or absent. Right? That's at the bottom of your slide. The next condition is AKA finders keepers, otherwise known as hoarding disorder. For finders keepers, and here I match the F with the acronym bottom left of your slide, was provided to us by a former medical student of mine, Anita. Obviously, hoarding, the H did not fit neatly into the acronym. So one of my students came up with an alternative name for hoarding disorder. So hoarding disorder, as we will refer to it in this slide, finders keepers, is defined through a persistent difficulty discarding or parting with one's possessions. There's also a perceived need to save the items, as well as distress associated with discarding them. All of the above will result in the accumulation of possessions that clutter the living area and therefore impact functioning. So that's hoarding disorder, as we would refer here to finders keepers. And just so I do my due diligence, FDNY as well as Full House are other names provided to me by medical students to fill in the acronym for hoarding disorder. What's interesting here, Full House, is that for me it is mindful, or it does remind me of a very brief scene, at least a screenshot in the movie we're about to see. Now, what you see in the back of Brody on this screen, and this capture, is Quint's cabin. That's Captain Quint's cabin, say that quickly. I don't want to go so far as to say that therefore Quint has hoarding disorder. But nonetheless, his living space and his active living area is quite cluttered due to the accumulation of possessions. And when we watch the movie, I just want you to take note of that, because you're identifying that, I think, is noteworthy and probably provides the hidden clue as to what this movie is really about. And so, and again, I'm going to give you a hint, it's not hoarding disorder, but it is something that I think is critical in understanding JAWS. Hoarding disorder, or hoarding, was actually a DSM criterion of obsessive compulsive disorder, the condition we're going to get to next. Because of a TV series, it became so prevalent that the American Psychiatric Association decided to flip it off and create its own disorder. So hoarding is no longer a DSM criterion for OCD, but is its own illness. Again, hoarding disorder is part of the before, the obsessive compulsive and related disorders, the next condition of which is obsessive compulsive disorder, or OCD. You'll notice that we're going to a different term here. And quite frankly, the only reason why I'm going to click on this term, obsession, and don't continue the conversation of the preoccupation is because the American Psychiatric Association decided not to name this condition preoccupation compulsive disorder. Because if they had, we would still talk about OCD as being hallmarked by preoccupations and having to rename it PCD, preoccupation compulsive disorder. Doesn't really sound right. So we'll stick with the original terminology and we'll click on obsession. And it brings us right back to one of the more iconic characters in literary history, and that's Captain Ahab. Many will discuss Melville's character as having obsessive compulsive disorder. And I wish I had included some references on this slide. There are more than a few. Captain Ahab is regarded as the quintessential fictional character demonstrating OCD. The definition of this condition is relatively straightforward. If someone presents with clinically significant obsessions, if someone presents with clinically significant compulsions, or if someone presents with both, they likely have OCD. So relatively straightforward. I want to talk a little bit about compulsions, and I want you to think not only right now, but when you watch the movie, how this relates to the very scene I identified earlier, and that's that of Captain Quint's cabin, where obsessions are maladaptive thoughts. Compulsions are maladaptive behaviors. Specifically, they are repetitive behaviors that an individual feels driven to perform so as to reduce anxiety. Here are the specifiers, tick related, and again, the severity of insight. Fair to good, poor, absent. Here is one of the references pertaining to Captain Ahab and diagnosing him with obsessive compulsive disorder. And on this website, he is referred to having monomania, defined as the pathological obsession. So pathological here describes clinically significant distress or impairment. When we say pathological, when we say clinically significant, we mean disordered. Here, monomania is the pathological obsession with one subject or idea. Again, in Melville's Moby Dick, an obsession causes monomania in its main character, in Captain Ahab. So, in brief, Captain Ahab, that's Ahab, A-H-A-B, is afflicted with clinically significant obsessions. Therefore, he likely has obsessive compulsive disorder. And again, I want to emphasize the word disorder because it is pathological. Right here in front of you, that's the first sentence. He has a pathological obsession. He has obsessions that are clinically significant. That is the definition of obsessive compulsive disorder. Well, what can we learn from him? And by the way, since his remake, his repackaging is Captain Quint, the captain in Jaws as well. Well, whatever we say pertaining to this slide at this point of our conversation must be provisional. When we begin to discuss a film, any diagnoses that we may consider must be considered provisional diagnoses. We get this through information from the film. We get this from a fictional account of the history and physical. Right? The history and physical, aka the psychiatric evaluation, applied to film, results in our recognition that Quint is the survivor of the U.S. Indianapolis that occurred back on July 30, 1945. And he's currently employed as a captain. He's a local fisherman. This much we know from just having watched the film. This much we know from the patient's history, Quint's history. On physical exam, more specifically the mental status exam, the MSE is part of the physical examination. We know that he has clinically significant deficits in thought content. Specifically, he demonstrates obsessions, not unlike Ahab. So that's where we are with this particular character at this point in our discussion, at this point of our evaluation. By the way, the T highlighted in thought content matches bottom right of your slide, the acronym for the different components of the routine mental status exam. I don't have the reference up here. It's Rapid Cycler Press. That's cycler with a PS. ABC Stamp Liquor is the acronym that reminds us of the different and separate components of the routine MSE, the T in stamp being thought content. So we talk again about formulating the most likely diagnosis with respect to a biopsychosocial perspective. Well, treatment then would follow that same exact perspective. When we institute or implement a treatment plan, it must also address bio, psychological, and social factors contributing to the onset or perpetuation of a disease state. When we look at the psychological aspect of a biopsychosocial treatment plan, the focus primarily is on psychotherapy. And through discussion of psychotherapy, we can now begin to define or identify a couple of defense mechanisms. That is, what would a therapist perhaps be focused on when discussing what is going on with Captain Quint within a psychotherapy session? Well, the defense mechanisms that underlie obsessive compulsive disorder include isolation of affect, usually abbreviated isolation, and undoing. Isolation of affect is the separation and isolation, that is, to one's subconscious, of an affect from an idea. So anytime we're engaged in a discussion, we are in concert acknowledging both an idea and the emotion related to it, aka its affect. Isolation of affect is that subconscious process, specifically the subconscious process of the ego, that allows for the separation of those two components so that the idea may continue in conscious awareness, but the affect, the emotion that was formerly attached to it, is isolated in our subconscious. This allows us to be discussing a particular topic, yet not be emotionally invested in it. Unfortunately, isolation of affect is not going to isolate the affect indefinitely. Over time, that isolated affect is going to slowly but surely come to conscious awareness again. And when it does, an individual must resort to a secondary defense so as not to become consciously aware of it. That's what ego defense mechanisms do. If they choose the defense mechanism of undoing, defined here as the attempt to atone for or erase a negative action, impulse, or idea by performing behaviors that are opposite of or correct it, that's undoing. So an individual has isolated their affect. They become anxious because that affect is slowly but surely coming to conscious awareness. And now they clean. Now they count. That's as a product of undoing. So through isolation of affect and undoing, an individual may present with compulsive behaviors. Right? So, and all of this, defense mechanisms in general, would be something addressed in psychotherapy. In concert with psychotherapy, there are FDA-approved medications for obsessive compulsive disorder, including those from the class of antidepressants labeled the SSRIs. Fluvoxamine is one example, as well as the other class of antidepressants, the tricyclic antidepressants or TCAs. The example here is clomipramine, and this is just a short slide on clomipramine. Again, clomipramine is a tricyclic second-generation antipsychotic. I take that back. Let's just say it's an older antipsychotic, FDA approved for OCD. As a TCA, as a tricyclic antidepressant, the focus here on the A, antidepressant, this medication has also gained approval through the FDA for treatment of major depression as well. Recurrent hair pulling disorder, aka trichotillomania. This condition is defined through the act of recurrent pulling out of one's hair, resulting in hair loss. The individual has repeated attempts to decrease or stop the act. And then the final condition in this chapter of the DSM is excoriation disorder. This condition is similar to recurrent hair pulling disorder in that the individual has recurrent behaviors, but instead of pulling out one's hair, it's picking at one's skin. And that usually results in skin lesions. And then again, similarly, there are repeated attempts to decrease or stop the skin picking. This acronym before, bottom left of your slide, shapes up quite well. Again, finders keepers, aka hoarding disorder, is closely related to obsessive compulsive disorder in as much as hoarding used to be a DSM criterion for OCD before being split off as its own disorder in 2013. So it's nice that finders keepers F and obsessive compulsive disorder O are back to back in the acronym. Similarly, recurrent hair pulling disorder and excoriation disorder are very closely related. One obviously has a clinical focus on hair and hair loss, the other skin and skin lesions. Otherwise, they're the same condition. And I think notably, the R and the E juxtaposed in the acronym remind us of that. So before actually, pun intended, spells out quite nicely. Not only does it allow us to remember the 5 conditions that make up the obsessive compulsive and related disorders, but I think in a sequence that reminds us of the associations of finders keepers and OCD, as well as this slide attests recurrent hair pulling disorder and excoriation disorder. And again, just a quick check. Everybody can see this okay?
Yeah.
Good. All right. Back to our original outline. The first session focused on the obsessive compulsive and related disorders. We're going to go to Roman numeral 2 now. This chapter in the DSM kept the older name from the previous revision of the DSM, the anxiety disorders. I want you to look closely at the name of this boat. This was taken directly from the internet, and Paso Grill, Florida is a real town, and that's the original picture. And that's a copy and paste from its website. So it does exist. And the reason why I wanted to bring this up, and I think whether it's the next break, whether it's after this presentation, I ask that you search for this website, check out what the website has to offer. I want you to remember the name Paso Grill because that will be the acronym. That is the name of the boat, the Miss Paso Grill, for the anxiety disorders. So we start out with medication/substance induced, or MI. The first 2 S's are specific phobia, followed by selective mutism. PAS is panic, agoraphobia, separation anxiety disorder. The SA is social anxiety disorder. And then GRIL includes generalized anxiety disorder. Rule out another medical illness, that's RILL. And then E is etc. And etc. in the DSM means other versus unspecified anxiety. The differentiation of which we're really not going to get into today. So we'll start off with a case study of a 45-year-old who presents with a chief complaint of panic. They report insomnia for several years, for which they recently underwent a sleep study. Upon discussing the results of that sleep study with their prescriber, they were provided a prescription for modafinil. The patient now presents to you with anxiety, irritability, and with a noted tremor. Don't need anybody to necessarily unmute. This is just, I think, a prompt for the next slide set. The single best answer here is 3. You see that the time of onset is consistent with the prescribing of the modafinil, the stimulant, So their anxiety would be attributed to a medication-induced anxiety disorder. In this instance, we simply look at the anxiety and the anxiety disorder as a side effect of the medication, specifically a direct physiological effect. And in this case, it was a medication. If you look at the title, top of your slide, it could be medication or substance induced. And a substance can include a medication as well as any drug, a toxin, or even herbal therapy. I provide this list as common medications that, as a side effect, as a direct physiologic effect, can induce anxiety. Any medication, if you look at the first two bullets, any medication that can increase sympathetic tone or decrease that second bullet, parasympathetic tone, that is lower acetylcholine, results in the same endpoint of increased anxiety. So again, the sympathetic nervous system, that first bullet, and the parasympathetic focus on neurotransmitters. The sympathetic nervous system focuses on dopamine and norepinephrine, abbreviated here DA and NE, and anything that enhances that will increase anxiety. The sympathetic nervous system acts in equilibrium with the parasympathetic, the main neurotransmitter of which is acetylcholine. So the opposite of dopamine and the opposite of norepinephrine is acetylcholine. So anything that increases dopamine or norepinephrine or decreases acetylcholine will result in anxiety. In addition to all of the above, thyroid hormone, steroids, and methylxanthine derivatives. Xanthine is a chemical analog to caffeine, and there are over-the-counter cold preps and arthritis remedies that include methylxanthine and therefore include this, this drug constituent that is structurally similar to caffeine. So pretty straightforward that anything containing xanthine or methylxanthine through its mechanism similar to caffeine will increase anxiety. Shifting away from medication and focusing more on substances, I want to return to the story of Moby Dick. And I want to talk about the three mates of that ship, the Pequod. Here, I will encourage anyone who wants to unmute and tell me what they know of the three mates, the first, the second, and the third mate of Captain Ahab's vessel. Anyone? All right, then we'll get started. As I know all of you knew, but are just too shy to unmute, chapter 26, titled Knights and Squires, introduces us to those mates of the Pequod. We meet the first mate. His name is Starbuck. He's pragmatic and he's reliable. He believes that it is rational and even necessary to fear whales, and his reverence for nature inclines him towards superstition. He is characterized by the other officers of the Pequod as careful, although this term is relative when used to describe a whaler. Now, I chose this excerpt very carefully because there are a couple of things in here, not the least of which is the name of the first mate, but also that he's prone to superstition. He's quite thin, and as I said before, prone to superstition, aka the overvalued idea. Well, some of you may recognize that the name of the coffee chain founded in Seattle was inspired by the first mate of Melville's novella. The founder, or one of the co-founders of Starbucks, the coffee chain, was a big fan of Moby Dick. Matter of fact, the initial name of the coffee chain was supposed to be the Pequod, but the other co-founder disagreed, didn't quite think it was marketable, so they decided to resort to Starbucks or Starbucks as the name of the coffee. Interestingly, if you begin to look at all of the different drugs that can induce anxiety, that is a substance-induced anxiety disorder, caffeine would be towards the top of your list. So whether or not that's just basically intuitive to you, and it should be, or if you remember, I think a little bit more creatively, that the first mate of the Pequod was Starbuck, and anybody who ever says that name instantly thinks of coffee or caffeine. That's just another way to remember one of the drugs that can induce anxiety. The next chapter introduces the rest of the ship's officers. Next in line is the pipe-smoking second mate named Stubb, a native of Cape Cod, always cool under pressure, possessing impious good humor. By the way, I think I spot Stubb very briefly in the movie you're about to see. I'm not going to give you the timestamp. See if you can actually spot him as well. Stubb is street slang for cannabis. So along with caffeine, cannabis is yet another example of a drug that can induce anxiety. And then the third and final mate is Flask, a native of Martha's Vineyard. Ironically, perhaps not so ironically, where this film, Jaws, was shot. Melville portrays Flask as a man whose appetite cannot be sated. In attempting to satisfy his appetite, Flask becomes even more hungry. Well, when you think of Flask, you may think of crystal meth and therefore stimulants. And yes, stimulants along with caffeine and cannabis can induce anxiety. Another thought that might come to mind when thinking Flask is that which you can keep alcohol, right? So put alcohol on that short list as well, along with stimulants, along with cannabis and caffeine. By the way, if that list is growing a little too long for you, and if you don't intuitively think of Moby Dick in general or the three mates of the Pequod in particular, it might be easier to simply say, you know what, all substances can actually induce anxiety with three exceptions. And those exceptions may themselves be remembered by another acronym, SON, S-O-N. So sedatives, opioids, and nicotine would be the exception to the rule if you just resorted to the idea that everything else can induce anxiety. By the way, on the right side of your slide, again, I think a fairly significant moment in the movie Jaws, the film you're about to see, and we could discuss why following the film. If SON would be the exceptions to the rule, and therefore everything then induces anxiety, you do have to remember that there are three withdrawal states that can also induce anxiety: withdrawal from sedatives, opiates, alcohol, and cocaine may all induce an anxiety disorder. I also found it interesting, again, we could discuss this more following the film, and this is in order of appearance, that cannabis, alcohol, and caffeine are portrayed in this film. Specific phobia. Once you definitively rule out an quote unquote organic etiology of one's anxiety, then you begin to investigate the mental disorders within the anxiety spectrum. Part of investigating that organic etiology would be attributing the anxiety to the direct and physiologic effects of a substance. So it's pretty apropos that following MI following medication / substance-induced evaluations, we begin a list of the actual anxiety disorders, starting with specific phobia. Again, bottom left of your slide, Miss Passagrill, the name of that boat, will light up consistent with the first initial of the illness's name. Phobia is alluded to several times, specifically for Captain Martin Brody, or excuse me, Sheriff Martin Brody, in Peter Benchley's Jaws. He presents chief complaint, CC, chief complaint, as uptight and anxious. And here is a copy and paste directly from the script. We all know about you, Chief. You don't go in the water at all, do you? To which Brody responds, "That's some bad hat, Harry," which many of you will recognize has flipped to its own production company. Chief Brody, you are uptight. So uptight is nothing more than a layperson's term for anxiety. Well, specific phobia is a fear that's cued by an object or situation. And whereas in the past, the American Psychiatric Association created specific terms for each specific object of focus, we've gone away from that now. So the good news is that you do not have to memorize 50 to 100 different types of specific phobia. The APA has now simplified this as any phobia falling within 4 basic types or 4 base types. Those subcategories conform to the acronym BASE. So blood injection injury, a quick copy and paste from a post on social media that I saw, a physician followed by our own medical school. I found very interesting, consistent with blood injection injury. A colleague just emailed that she'd be slow to reply today. She just had her second COVID shot and had passed out. Never heard of people fainting routinely after vaccinations. These times are not normal. Do not see this doctor, because this doctor did not attend this seminar or any seminar similar reviewing the anxiety disorders. The fact of the matter is that all MDs should have heard of people fainting routinely after vaccinations. That is called specific phobia. More specifically, specific phobia, blood injection injury type. The A stands for animal type. That's Brody, his fear of sharks. It's the water, but we're going to find out later it's really sharks. Situational type, and then environmental type. In clinical practice, if an individual doesn't neatly fit into one of these artificial categories, B, A, S, or E, we simply say other. The irony here is that one of the more popular or prevalent phobias, prevalent specific phobias of phobia to clowns, is in that grab bag category of other, right? It's not blood injection injury. A clown is not an animal, a situation, or something in the environment. So even though we think of it as a potpourri or a grab bag category, other, one of the more prevalent specific phobias to clowns would be in that very grab bag category. Here's another part of the script a little later, and these are in time sequence. Get out of that boat, to which his son yells back, "Hi, Dad, just a little longer, please." Brody's wife, it's his birthday tomorrow. Brody, I don't want him to go in the ocean. He's not in the ocean, he's in a boat. He's not going to go in the water. I don't think he'll go in the water again after what happened yesterday. Now, you'll, again, realize that this particular part of the script is juxtaposed to when Sheriff Brody hyper-vigilantly gets everybody out of the water for no reason at all. It's a false alarm. It's a false false positive. It's a false alarm. So what we're laying here is the etiology of how one might develop a phobia, in this case to water, in this case perhaps to a shark. And it's really focused on Brody's son. He was traumatized by his father getting everybody out of the water for fear of a shark being spotted. That incident, that event, could result in this child avoiding the water into his adult life. Again, you'll be the only rational man left on this island. This is Brody now talking to Hooper. Where are you going? He says back to Hooper, I'm going on the Aurora. The Aurora, what is it? It's a floating asylum for shark addicts, the reply from Hooper. Pure research, 18 months at sea. To which Martin's wife responds, Martin hates boats. Martin hates water. Martin sits in his car when we go on the ferry to the mainland. To which he says, I guess it's a childhood thing. There's a clinical name for it, isn't it? Isn't there? And the answer is yes. It's called specific phobia. So right out of the script, and the clinical focus here being on Sheriff Martin Brody. Why? Well, depends on your theoretical perspective. In each case, we'll call it biopsychosocial, but when we focus on the psychological component in answering that question, why, one theory comes from Sigmund Freud. A couple of things from this slide. Number one, perhaps not as important, is Freud's case study of little Hans. The reason why I want to bring this up is because in our field, I think it's a good idea to bring up this landmark case study in association with specific phobia. Even though we can discuss and even debate whether or not this is really held up over time. It is a landmark study, and as such, maybe it's just pub or happy hour fodder for us, but good to know nonetheless. Some historic value. What I think is much more clinically significant or clinically useful is the idea of displacement. That's the final bullet. The bottom line is this. When we come to phobias, when we come to phobic avoidance in general, the object usually is something that might be a metaphor or a symbol of something else that's going on. That's something else that's going on is usually subconscious. So the individual displaces their fear onto an external object and then becomes avoidant of that object. That is much less threatening than acknowledging what the true, hidden, latent fear is. That's the general concept, analytical, or I should say analytic, or dynamic, i.e. Freudian concept of a phobia. Another perspective, yet still psychologically based, is that of the behaviorist. And here we focus on the work of Watson and his case study of little Albert. So we shift from little Hans to little Albert. Little Albert was conditioned to fear rats and rabbits. This is part of classical conditioning, otherwise referred to as Pavlovian conditioning or Pavlovian learning, where the response of anxiety is conditioned to a rabbit. I'm not going to get into the details of how that was done. Again, it's a landmark study, so there should be significantly easy access to review the actual details of the case of little Albert. Whether you're coming from a purely biological, psychological, or social perspective, and I, again, proposed, albeit briefly, 2 examples of psychological theory, that is the etiology of phobia. In every case, we can then look at what might predispose, precipitate, and even perpetuate the behavior. So for instance, if we look at classical conditioning and the pairing of a neutral stimulus with an unconditioned stimulus, if we're looking at aspects of the case of little Albert, that might precipitate the fear response, but it may not necessarily perpetuate it. So the perpetuating factor might more be aligned with operant, not classical conditioning. Right? So not classical, but operant conditioning, specifically elements of negative reinforcement. And I think this 2x2 rubric explains exactly how. So let's just introduce this 2x2. Again, this is now morphing into a discussion of operant conditioning, a type of learning different and distinct from that which Pavlov described, and that was classical conditioning. Number one, the clinician should always ask, is behavior being strengthened or weakened? Right? So if we're looking at someone like Marty, if we're looking at Marty's son, what we're looking at is avoidance behavior, and avoidance behavior being strengthened. That is, whatever's going on, there's a persistence or strengthening of Martin and or his son's avoidance behavior. When we acknowledge that punishment will always result in weakened behavior, these two characters must be dealing with reinforcement, highlighted here in green, and cannot be subjected to a punishment paradigm. Because if they were part of a punishment paradigm, that bottom row, the avoidance behavior would be weakened, not strengthened. Reinforcement always strengthens behavior, punishment always weakens it. So our first question in observing any case is, in describing the behavior through operant conditioning principles, is the behavior being strengthened or weakened? And in this case, we can easily say that the character's avoidance behavior is being strengthened. After we decide that initial step, the second and final step is to ask, well, is something being added to result in this, or is something being removed, subtracted? If something is being added to the equation to result in this behavior, we're going to use the adjective positive. If it's being removed or subtracted, we're going to use the word negative. When we look at this condition, and what I mean is the condition of Marty and or his son, the focus on their avoidance behavior is strengthened by the removal of something. That is, they are not going in the water. So the removal of the water from their daily life, the removal of their closer proximity to sharks in their daily life is strengthening their avoidance behavior. So despite what may have precipitated or triggered this in the first place, the behavior persists, the behavior perpetuates because of principles related to negative reinforcement. Any questions about specific phobia and some of the principles that underlie the etiology of the condition, both as a predisposing element or factor, or even precipitating and perpetuating? The second S in the acronym again, by the way. I'm sorry, go ahead.
I actually have a question. Before, you mentioned all these medications that can cause anxiety. And one of the things that you put on there was cannabis, but I know that they also use cannabis to decrease anxiety. So can you explain that? Because I know that that's been one of the things that they've been talking about now.
It's a great question. Yeah. So there's a couple of points to be made here. When interacting with clients, consumers, and patients, I think it is critically important to relay the evidence-based literature. As clinicians, that is our role, is to look at what's been published in journals, peer review reports, etc., and distill that information and transmit it to the person that is coming to you for help, specifically the person that's coming to you for help of their anxiety. To date, there have been no published studies that support the use of cannabis in the treatment of anxiety. And clients, consumers, and patients need to hear that and need to hear it clinically. If they have drawn the assumption, if they have drawn the conclusion that cannabis or marijuana helps anxiety, reassure them that that message is coming from someone other than medical science.
Well, the reason I brought that up, yeah, I'm sorry. The reason I brought it up is because I'm a long hauler for COVID. I mean, I've been home for a while and I'm in this COVID support group weekly. And one of the things that all of us have, well, most of us, not all of us, have gotten from our doctors is because one of the symptoms is really bad insomnia. And so they have prescribed or suggested cannabis or a Delta 8 to help relax your body and help you go to sleep because of anxiety. Because let me tell you something, I mean, a year home it makes you anxious. so that's why I was asking that specifically.
It's a very, very common question. And I could tell you, as a consulting psychiatrist at Robert Wood Johnson University Hospital, which is our main hub in New Brunswick, we deal with this question all the time. So, one of the mechanisms by way in which cannabis alleviates anxiety or even improves insomnia is by the direct intoxication effect. And in that way, it really isn't that much different than just drinking before you go to bed and passing out. Now, it's a different mechanism in terms of where in the brain it may hit. But the bottom line is that it's a very similar, or there's an overlapping construct in that you're not really dealing with correcting a chemical imbalance. You're just baking your brain. And there might be consequences to pay. Now, the good news is that for most people, the risks or the adverse outcomes won't be there. That's the good news. The bad news is that for a percentage of the US population, there are going to be adverse outcomes. There are. And unfortunately, from my practice perspective, that's the skewed population I end up seeing. The people that come into the ER because of those adverse outcomes. So we've again, in the medical profession, you've got to be very careful. Individuals who gain benefit from cannabis or similar acting drugs, and this includes alcohol, for alleviation of their anxiety and or insomnia, and those two are very closely related, are number one, taking the medication as in a way other than as directed. These medicinal properties have been approved by our government and government officials, not our physicians. And people have to know that. And then on the other hand, while there are other FDA approved drugs available, missing out on those might be problematic. And for a select few, and I don't know the exact percentage, but I think it's less than 50%. I feel quite comfortable saying that. There are likely to be adverse outcomes of using drugs like alcohol and cannabis to alleviate anxiety. So you have to be very careful.
Can I just ask you one sub question to that?
Please.
Is there any distinction, or is there a distinction being made in CBD/THC? Because when they say cannabis, they're kind of doing the overall thing, but are they talking CBD or are they talking THC? But you kind of hit it with the intoxicating effect.
Excellent question. The answer is a definitive yes. All right. So CBD is not psychoactive, so the level of risk is significantly decreased, whereas THC is the psychoactive constituent of cannabis and carries a much, much higher risk. So if you're using CBD for anxiety, that you're conferred less. Now, it's not FDA approved either. There's been no double-blind, placebo-controlled studies to support the effectiveness of even CBD for any mental illness, including anxiety. So if you get benefit from it, that's wonderful. However, there are risks, but those risks are far less than if you smoke cannabis and are exposed to THC, which is a psychoactive constituent of cannabis. Again, no FDA approvals for cannabis either, for THC either, and the risks are much higher.
Thank you.
I had a question, actually a comment about JAWS, and it appears to be also an example of kind of like a mass creation of a phobia. And I, I love the ocean. I go in the ocean. It doesn't stop me from going in the ocean, but I can't not think about sharks when I'm in the ocean. I can't not. But it seems, are there other examples of math? Would you consider this something, does it have a word when it sort of affects so many people in terms of a phobia? It's just interesting how reinforcing that movie is to the severe fear of the ocean.
Yeah, and that product is why this film has its place in our culture, because in 1975 it just simply changed the way people went in the ocean. I mean, there was a lot of lost revenue down the shore because of this movie in 1975. I actually saw this movie when I was 6 years old in a theater. Well, we didn't have any streaming services, of course. And this was July, and it absolutely ruined my summer. We have a house, my grandfather did, on a barrier island down the shore, and on both sides of me was water, and I was paralyzed. I couldn't see the water from our home. Our home actually had to be in the middle of the island in terms of width. Couldn't see the water on either side, but I knew it was there. I heard it, and it just paralyzed me for the entire summer. You'll hear a layperson's kind of overview of this as mass hysteria or mass hysteria. I don't know if there is an arbitrarily agreed upon clinical term for that type of phenomenon, but it does exist. And for this particular film, we could argue that it is probably the #1 film that has resulted in that quote unquote mass hysteria. The other film that comes to mind, although I have to say I'm a little too young to have seen it. It was premiered before I was born. Is Psycho. I'm told by my parents, my aunts, my uncles that Psycho changed the way people provided hygiene to themselves. I mean, people took baths, not showers, after seeing Psycho premiere. So I've been told that's in a similar context. I don't know if Psycho had as great an impact as Jaws did with respect to people going in the ocean. And what you're looking at here is that second S in the acronym bottom left, selective mutism. This condition is new to the anxiety disorders chapter. This condition was previously published, DSM-4, in the child and adolescent disorders chapter. This condition is defined through a consistent failure to speak in specific social situations. Now, if an individual simply stops speaking, Scrooged, starring Bill Murray, that's not selective mutism. That's mutism. This selective mutism must be selective. That is, the individual may talk at home, they may talk outside with their friends, but in school they don't talk. That's selective mutism. Those deficits cannot be better explained by lack of knowledge of a spoken language or another mental disorder. And so if somebody goes to school and everyone's speaking in one native tongue and they speak in another native tongue and therefore don't speak, that is not selective mutism. And it must go on for at least 1 month, must be clinically significant. Those final bullets 3 and 4 are largely irrelevant. The main idea here is that the individual has a consistent failure in speaking in specific or selective social situations. And it's not better accounted for by a lack of knowledge of the spoken language. Case study, a 25-year-old presents with chest pain. They report being afraid of having a heart attack. The HPI, the history of present illness, includes a subjective sense of their heart racing, palpitations, and 3 similar episodes in the past month. Social history, SH, the individual is a smoker. 1, 2, 3, or 4. Right. So this introduces the illness of panic disorder. Panic disorder, in a general sense, is very easy to define. A panic disorder has, the definition has two components. That is, there are recurrent unexpected panic attacks that are clinically significant. That second component of clinical significance is straightforward. That applies really to every mental disorder published by the American Psychiatric Association. So for all intents and purposes, all we have to remember today is that panic disorder is defined through recurrent and unexpected panic attacks. Of course, that does bring up the question, well, then what's a panic attack? And before we address that, I just wanted to make a comment on clinical significance. Number one, the individual may have 1 month of worry or concern about attacks or some change in behavior. And while agoraphobia is an example of a behavioral change, I think one of the takeaways from this slide, and you can see the way it's built and constructed, an individual can still rule in without having agoraphobia. So I know panic disorder appears to be synonymous with agoraphobia, and it is true. Agoraphobia can serve as the example of a behavioral change and therefore an example of clinical significance. However, the absence of it does not necessarily mean the patient has escaped clinical significance, because there could be another change in behavior other than agoraphobia, or if not, the month of worry or concern still allows them to rule in. So that's a major teaching point here. What is a panic attack? Well, in terms of what may cause it, I broke this slide down into, again, some predisposing and precipitating factors. Predisposing factors focuses primarily on genetics and heritability, while precipitating factors, also coming from research, looks like there's an increase in lactate. That's a component of the blood, right? So, for example, we know that if somebody is infused this constituent, lactate, people that are predisposed are much more likely to have a panic attack than people who are not predisposed genetically, right? So when we think of predisposing and precipitating factors, you'll often hear about genetics, and you'll often hear about the studies that focused on lactate infusions and the susceptibility of those infusions in people who are genetically predisposed. I love this particular scene from Jaws, where we actually see the orca, the boat, beginning to sink, really. I mean, this is where the engines go. And what a pick for a metaphor similar to Fadala, coming from the bottom and erupting, right? Pushing for that unconscious, or from the unconscious, pushing for conscious expression. Boy, when this thing blows up, what a metaphor for a panic attack. The general definition of a panic attack is a discrete period of intense fear or discomfort in which an individual demonstrates 4 or more of the following symptoms. Now, I want to get a little bit into what I mean by discrete. Panic, that P word, is often something patients try to relay to a clinician. And it's really incumbent that we as clinicians ask patients to tell us more, because in the reply, if the individual does not provide their feelings, their anxious feelings, as being within a discrete period, often reaching a peak within 10 minutes and alleviating after about 30 plus minutes, then we're not likely dealing with a panic attack. If a patient tells you that they're here, they're presenting to your office, your venue, for better control of their panic, and they don't provide that discrete period, then they're probably more portraying feelings of being panicky. And here, that word is synonymous with anxiety. Anxiety, but not necessarily a panic attack. Well, within that discrete period, what symptoms? This is taken from Brain Calipers, again, Rapid Cycler Press again. The acronym itself is This Is Not Fun, and we have a nice little pick from JAWS, where I think any of us put in that scenario would agree that this is not fun. While the acronym is published, and I think it does a nice job of reviewing, these are the actual DSM criteria. In reading through this list once or twice, what I would prefer everybody simply do is acknowledge and agree that any client, consumer, or patient that presents with a constellation of these symptoms, 4 or more, looks like they're having a heart attack. And if you acknowledge that, and if you recognize that, then it's very easy to identify a panic attack, whether it's on a certifying exam, whether it's in clinical practice. And that is a panic attack with regard to its presentation, as well as its time of onset, is clinically indistinguishable from an acute myocardial infarction or heart attack. Now, the difference here is that while all of this caused by the heart muscle being cut off from its oxygen supply would define a heart attack, the same exact signs and symptoms without the heart muscle being disturbed is a panic attack. Well, how do you differentiate between the two then? Because if Dr. T is telling us they look exactly the same in clinical practice, what is a clinician to do? Well, it usually is routine blood testing to test for myocardial, that is, that heart muscle injury, as well as an EKG also to get evidence of potential myocardial injury. If the EKG is normal, if those blood tests return normal, that heart attack looking syndrome is a panic attack.
Dr. T, can someone have a heart attack because of a panic attack?
The answer is yes, but it is very infrequent. It is very infrequent that an individual's anxiety level gets high enough where they compromise oxygenation to the heart muscle, therefore having a heart attack. I would have to look in the literature to see if there's even a number that I could come up with, but I could tell you it is exceedingly rare that that happens. Treatment is biopsychosocial. That's obvious because treatment for any maladaptive behavior would always be biopsychosocial. Bio or biological treatments include medications, and the tricyclic that has been FDA approved for the treatment of panic is called imipramine. Multiple SSRIs have also gained approval, and because of their side effect profile, are more routinely prescribed for panic disorder. So again, imipramine is a medication. This is the brand name is Tofranil. This is a tricyclic, therefore it is FDA approved for treatment of depression, but it has an additional approval for the treatment of panic disorder. Well, again, I think this acronym shapes up quite nicely because panic disorder, like any mental disorder, must be clinically significant. One example of which would be agoraphobia. So it's very nice that agoraphobia follows panic disorder in the acronym. I'd like to get through agoraphobia and then take a 10-minute break. Agoraphobia is literally translated from fear of the marketplace, defined as anxiety about being in places from which escape may be difficult or embarrassing in the event of becoming symptomatic, one example of which would be having a panic attack, but there are multiple other examples. In psychiatry, panic attacks are the most common example in psychiatry, and therefore there are specifiers with or without panic. And those are those final two bullets. Irritable bowel, Tourette's are all examples of behaviors of which individuals might become embarrassed and therefore might develop agoraphobia. Fear of the marketplace. Well, one of the things you may buy at a market are peaches, and peach, PEACH, does serve as an acronym for the actual DSM criteria of agoraphobia. That is, different venues in which people may avoid, and they're listed here: parking lots and other open spaces, enclosed places, the A train, aka public transportation, crowds, and the H stands for outside of the home alone.
Dr. T, when I'm looking at that chart, the fear of enclosed places as relates to agoraphobia, is there not also claustrophobia?
So I think the clinical term is agoraphobia. Many people use the word claustrophobia. That's a clinical term. The actual mental disorder is agoraphobia. So in that way, claustrophobia would be a clinical term and a diagnostic criterion of the mental disorder labeled agoraphobia.
Got it. Thank you.
Yep.
Can you also address how migraines with aura can be a symptom of the panic attacks?
Yeah, I mean, I think the answer comes twofold. Number one would be that because of the sense of fear and foreboding with the onset of a migraine, an individual may begin to develop a conditioned response that includes anxiety. So at that point, the idea here is that the migraine, the medical condition, becomes very closely associated with anxiety or an anxiety disorder, the psychiatric condition. And those become paired. And therefore, anxiety becomes part of the symptom set of a migraine, whether it's with or without aura. So that's one mechanism in which this could work. There is a mental disorder. There is a descriptor of this, albeit in another chapter of the DSM, and it's called psychological factors associated with other medical conditions. And psychological factors associated with other medical conditions. In this case, the psychological factor is anxiety, and the other medical condition is migraine. So that's one of the contexts where I think any clinician would think to address both the psychological anxiety and somatic migraine components of the condition.
So what would be the most efficient treatment for a patient like that if all biological causes were ruled out?
So I think the gold standard would be a clinician that is duly trained in both neurology and psychiatry. So in this case, that individual who goes through that specialized training sits for both boards. They are a board certified neurologist and a board certified psychiatrist. From the neurology training, they'd be more than helpful to address the migraine. And from their psychiatry residency, they'd be more than helpful in addressing the anxiety. So that would be the gold standard.
And how would you find someone like that?
As I tell all my patients, you have to go through your insurance, and you have to see who is on their formulary, and therefore look at their board certifications.
Okay. Thank you.
Yep. Now, the other way that this might be paired, again, we're talking about migraine and anxiety, is through agoraphobia. If an individual is developing avoidance behavior for fear of becoming symptomatic in public due to their migraine,
yes.
Well, they have migraines and they have agoraphobia. They have two separate diagnoses. So in one way, they may have a single diagnosis called psychological factors affecting other medical conditions. But in this other scenario, there's two separate conditions. They have migraine, that's established, but they also have developed agoraphobia related to that migraine in as much as they avoid public spaces because of fear of becoming symptomatic due to their migraine.
Okay, thank you.
Any other questions? All right, we're going to leave it here. We'll stop here at separation anxiety disorder, and we'll say we're going to come back at 11:05. So if anybody has any questions coming out of break, we'll address them at 11:05. My plan here is to do a little bit more. We'll stop at or around, I would say between 11:30 and 11:45, and then look to boot up JAWS. That is that fictional case. Before we begin our third and final session of the morning, anybody have any questions coming back from break?
Yes, I have a question regarding panic disorder. I had a client who had a panic disorder. It only happened once. He has seasonal allergies and started wheezing and couldn't catch his breath. And of course, the more anxious he became about that, the less he could catch his breath. I helped him eventually, but I just had him jump up and down, walk around, do something to distract him. And I wonder if you had any thoughts about that.
Yeah, so first and foremost, and again, for those of you who may not know, my background is also in internal medicine. So I'm duly trained. And I've seen and I've treated COPD, I treated asthma on several occasions, especially as a resident. So first and foremost, if someone presented to me out of breath and panicky, the single best diagnosis here is an asthma exacerbation, and that's it. And what we tried to do is make sure that general internists understand that most, if not all, of quote unquote their illnesses have behavioral components. So get used to it. You don't need to consult a psychiatrist every time a patient has a behavioral aspect of their medical condition. And there's no better example of that, arguably, than the feelings of anxiety and panic in someone who is having an exacerbation of their asthma, an asthma attack. Now, having said that, if the anxiety in the context of their asthma takes on a life of its own, and they begin to have panic attacks, where when they put the pulse ox on, they're oxygenating 100%, and they're told, well, that 100% oxygenation, perfect, is not consistent with an asthma attack, then we're on to something different. And then I think the psychiatrist has a role, or perhaps somebody like me, duly trained, where I can address their asthma as their prescribing internist, and I could also address the anxiety disorder they developed as a practicing psychiatrist as well. So that can happen too. And in that situation, again, I think the single diagnosis that would be befitting would be psychological factors affecting other medical conditions. Although it's not part of the anxiety spectrum disorders, it's parked somewhere else in the DSM, a different chapter, but that's the condition we're talking about here.
Thank you.
Yep, you're welcome.
Doc, I just had one clarification question, please.
Sure.
When you spoke about the migraines and agoraphobia, avoiding places with the migraines due to the possibility that you would experience some symptoms or see experiencing of the symptoms in public. Did I hear that right?
Yeah, that's right. Yeah. So with people who have migraines, and again, it's any illness, but in this case, we'll use migraines as an example. If they become fearful of having a migraine attack in public and decide, well, the best way I'd like to address this, the best way I think to approach this is simply not go out. Then that's agoraphobia.
Is the reverse also true or possible?
Reverse meaning that they're not going out because of their anxiety?
Yeah, like can you experience migraines due to agoraphobia?
I would say no. However, there's extenuating information here. While I think the easy answer is no, I'm going to give you a mechanism in a way this may make sense. And I'm going to replace the clinical term agoraphobia with the more general term of anxiety.
Yes.
Okay.
Okay.
Anxiety.
Fair.
Again, so let me rephrase the question. Can anxiety exacerbate a migraine episode?
Better question that I was trying to get to. Yes. Go ahead.
And I think the answer is yes. I think the answer is yes. There are several predisposing factors, one of which is anxiety. And yes, individuals who have anxiety, I think, are at greater risk for developing a migraine headache. And I say this with a little bit of a caveat, and that is, even if you ask the most seasoned neurologist, there is not 100% consensus of what causes a migraine. So there's a large unknown here. So I think it would be ridiculous for me to say, even though we don't know the true mechanism, what we do know is that anxiety never plays a role. I don't think I'd be able to say that. And even when I say it out loud, boy, that doesn't sound right at all. All right. So I would feel uncomfortable making that statement. And to the extent that I am, then the answer is yes, that anxiety likely does play a role, albeit one that's largely unknown, because the true mechanism of a migraine itself is somewhat unknown. But yeah, I think that migraines would predispose individuals to multiple conditions, including migraine, as anxiety.
So I have a question. So when you're treating a patient that has migraines with aura connected to anxiety, what comes first, the horse or the cart? Like if you have, this person has gone to a neurologist, has tried a variety of, Imitrex and Nurtec and all of that stuff. The person is in therapy, take Zoloft. So if none of that is working to prevent the aura with the migraine, because often what happens is they get the aura and then the anxiety, jumps right in, and it's like a vicious cycle. And, for a 26-year-old young woman, that's not a great combination. So, it's like I'm kind of at a loss how to treat this person.
Right. So a couple of thoughts, and with what information I believe I understand. Given that it sounds like the treatment plan for the anxiety or anxiety disorder is gold standard, what I heard was that the individual was on an FDA-approved medication, is being provided psychotherapy. If we are to say that if there's an anxiety disorder, and if that anxiety disorder is predisposing to more frequent migraine headaches, well, it looks like that component's been optimized. So at this point, assuming that there has been optimization of care for the anxiety disorder and therefore how it predisposes to the migraines, the focus then should be on the migraine itself, meaning that we're probably best to discuss and formulate and therefore treatment plan for the migraine in the context of that other condition I mentioned, psychological factors affecting other medical conditions. It's within that construct that we should address the migraine. And that means addressing the migraine as well as its very common behavioral component of anxiety. So there's a little bit of a shift here. We've acknowledged that anxiety can predispose to more frequent migraines, but we focused on that and we treated that to the best of our abilities. Now we have to shift clinical focus to the migraine itself within the construct of psychological factors affecting other medical conditions. And there we appreciate that anxiety and perhaps debilitating anxiety may be part of the migraine headache and how best to address that. And again, that begins what I believe to be the gold standard of someone who is duly boarded, that is, has medical boards for both psychiatry and neurology.
Yeah. Thank God for our wonderful insurance system.
No comment. I've not taken, and again, apropos for the actual film we're watching today, I have not taken that bait for the past decade plus since I've been providing these seminars at the Center of Alcohol Studies, and I'm sure as heck not going to take that bait on my final presentation. So no comment.
Yeah, I know I'm not asking you to comment. That was my own
Understand.
is coming out.
Understand. I'm going to share now with us. All right. All right. So separation anxiety disorder. I could post this later. We actually created a music video. I actually helped produce a music video of which we reviewed multiple medical conditions, including the anxiety disorders, as this slide attests, specifically separation anxiety disorder, through Billy Joel's Miami 2019. I introduced this video primarily to have this slide at 1:44. That's 1 minute and 44 seconds into our video, which details a movie called Cloverfield. So here's some very brief background on Cloverfield. I'm going to run right through these slides. If you've seen this movie before, you're going to pick up on what I'm going to refer to in the subsequent slides. If you haven't seen this movie, it's no big deal. You'll just miss the context of the film. I will say, however, again, giant, right? These are giant monster films, homage to King Kong. I would strongly suggest you catch this film. It's a very good film, especially if you like films like King Kong versus Godzilla, etc. So I'm going to really spin through these slides. By the way, the movie itself is found footage, meaning that the dates are very well detailed. And on some of the dates that occur in the film through this found footage retelling, I have dared my medical students to go to Coney Island where this film is set. And if you take a selfie, I give you credit for the day. You got to take part of the didactic, of course. My idea here is that if you hear details of the anxiety disorders taught through Cloverfield at the place where Cloverfield took place, then you're more inclined to remember the information than if you sat in my stuffy classroom and did it then. Well, these are three of my students that took me on task. And one of them, and I won't name who, turned out to be my resident and is currently a rising third year. By the way, that's Mark all the way to the right. What you need to know is that this condition called separation anxiety disorder is defined as developmentally inappropriate anxiety concerning separation from one's attachment figure or attachment figures. That begs the question very quickly, what do we call developmentally appropriate anxiety when one is separated from their attachment figure? It's usually the mom. And the easy answer there is, well, that's separation anxiety, and that's normal. This, of course, this slide as titled, is when that normality becomes abnormal, when it becomes clinically significant. And one of the hallmarks of clinical significance here is where in one's development they are. And we're going to get to a slide that repeats this in a little bit, but separation anxiety peaks at or around 18 months. So if someone at or around 18 months begins to throw tantrums when separated from their mom, that is normal. Right? On the other hand, when someone is 18 years and does that, that's not considered normal. And one of the abnormalities that can explain such behavior in an 18-year-old might be separation anxiety disorder. This disorder usually manifests in children. So the individual doesn't have quote unquote normal development, and then at 18, all of a sudden develop this. Its time of onset is usually younger. Now, not 18 months of age, but certainly 5 years, 6 years, 9 years of age, there is evidence of separation anxiety disorder. In that age range, 5 to 9, children have a very difficult time putting words to their feelings because they're children. So they are not likely to tell their mom, their dad, their physician, their pediatrician, I feel anxious. That's just not what children do. They tend to communicate nonverbally. And therefore, as a form of nonverbal communication, they tend to communicate this through symptoms, both somatic, examples could be a stomach ache or headache, or behavioral, tantrums. Separation anxiety disorder strongly suggests that it's where the individual is separating from that is problematic, not necessarily where they're going or headed to, right? If their fear, if their anxiety is about where they're going, we're talking about something else. It's the actual separation from start point that defines this condition. I mentioned before, individuals may be fixated during a time where this is developmentally normal. That's between 10 and 16 months of age. I may have said 18, 16 months of age. And then as an adult, they may regress back to that stage and therefore demonstrate symptoms of separation anxiety disorder. All right. The cool thing about discussing the movie Cloverfield, again, similar to Jaws, another film about Giant, is that the film itself was inspired by an event that Matt Reeves experienced as a child. Matt Reeves was the director. And at a circus, one of the elephants became agitated. And sitting close to the first row, a young Matt Reeves realized that if this elephant had the thought, everybody in his section would be put in imminent danger. And what was further interesting is that not only was this a huge elephant, but it was also a baby elephant. And with this experience as a child, he began to pen the script, the manuscript that became Cloverfield, the 2008 feature film. His quote is that there is nothing scarier than something huge that is spooked. So what does this mean for the actual movie Cloverfield? And again, if you've seen this movie, you're going to know instantly what I'm talking about. If you haven't seen it, picture King Kong taking over Manhattan. Picture the end of King Kong itself, that last 10 or 15 minutes, itself becoming a feature-length movie and expanding those 15 minutes to 90 minutes. That's what Cloverfield is about, a giant monster that overtakes Manhattan. The backstory to Cloverfield, and it might be the same as King Kong, and actually I believe it is that this monster, this giant monster, is a baby. And it's a baby that is spooked because it was separated from its mom. And all this baby wants to do is find mom. And when it can't, it throws a tantrum. And unfortunately, the Empire State Building gets in the way. So when we analyze films, when we take films and we begin to formulate what's going on, I usually give my audience the choice as to where to start. And about 10 times out of 10, they pick their favorite character. Very seldom do people pick the monster, especially when it's a giant monster. When we discuss and we case formulate the fictional case known as Cloverfield, that 2008 film, there are a lot of characters that you can choose from. And one of them, very, very rarely chosen to discuss, is to take this film from the perspective of the monster itself. And if you had, separation anxiety disorder would be the single best answer. Individuals with social anxiety disorder will often present looking very similar to those individuals afflicted with separation anxiety disorder. So upon presentation, these two conditions look very, very much alike. And it's interesting that that is the case, because if the 2008 film Cloverfield is a fictional case of separation anxiety disorder, its sequel, 10 Cloverfield Lane, is actually a fictional case of social anxiety disorder. Now I'm going to skip the actual case study. I'm not going to bore you with the details of 10 Cloverfield Lane. We'll just get right to the actual definition. And if you haven't seen this movie, you're going to have to take my word that there is a character in this film afflicted with social anxiety disorder. And no, this time it is not the monster. Individuals with social anxiety disorder are hallmarked by a fear of humiliation or embarrassment in social or performance situations. That is, it is the social or performance situation itself that invokes the anxiety, not where they're separating from, it's where they're going to. A very common example is often referred to as performance anxiety, getting up in front of crowds, getting up in front of a class and providing a lecture. Performance anxiety. Performance anxiety is not a mental disorder. It's a clinical descriptor, but it's a very common example of social anxiety disorder, so common that in 2013, the APA decided that the quote, performance only, end quote, specifier should be added to the diagnosis of social anxiety disorder. So individuals may have social anxiety disorder with or without performance only. The treatment is biopsychosocial. So CBT is usually the gold standard for psychological intervention for social anxiety disorder. And on the other hand, there are FDA-approved medications, including the SSRIs. But outside of the SSRI class, the monoamine oxidase inhibitor, these are third-line agents used to treat depression, have also gained approval. The reversible monoamine oxidase inhibitor has been FDA approved not only for depression, but for social anxiety disorder as well. And another, albeit non-antidepressant, that is often used for the performance only subtype is a beta blocker, propranolol. Here, individuals who have quote unquote performance anxiety, specifically social anxiety disorder, performance only subtype, take propranolol about a half an hour before their lecture, before the event, before their speech. So they slow the heart rate and they slow other biological parameters so that they are not primed to become anxious in front of the crowd. I think I'm going to stop here. I wanted to get through those conditions because for all intents and purposes, we went through several anxiety disorders that often present with avoidance behavior. So panic with agoraphobia, separation anxiety, and social anxiety may present looking, and I want to really emphasize the word present to clinical practice, looking exactly the same. What helps differentiate is what the true fear is. So individuals with agoraphobia will tell you, hey doc, it's where I'm going that's the problem. That is, my specific fear is of becoming embarrassed in case I become symptomatic, perhaps due to my migraine. That's agoraphobia. People with the condition we just discussed, social anxiety disorder, will tell you something similar. Hey doc, it's where I'm going that invokes my anxiety. However, more specifically, it's about the social or performance situation itself. For instance, performing in front of a crowd, not necessarily becoming embarrassed. Therefore, this is not agoraphobia, but more accurately, social anxiety disorder. And finally, separation anxiety presents very similarly. However, when asked, the patient will tell you that it is not where they're going, but where they're separating from that invokes the anxiety. Usually it's from the primary caregiver because usually the time to onset is in childhood. When we come back from our film, we'll pick up our discussion on generalized anxiety disorder. So I want to stop here. It is 11:30 now. Again, we could take another 10-minute break and say that the movie will begin at 11:40. But before we do, let me just stop sharing our screen. and ask anyone if they have any questions. All right, well, if no questions, we'll stop here and we will look forward to coming back from break and starting the film at 11:40. Thank you.
I haven't seen this movie, I don't think, since it came out. And now I remember why I didn't watch it again. It's so terrifying. It's so well done. But I think that Quint's, certainly his obsession was fascinating, and each one of them had their own
What we could do
story.
then, if you, well, difficult time there. Let's see here. Nope, I thought somebody posted something in the chat room. No worries. What we'll do is I'll go ahead and then share our screen.
Anthony, can you hear us? I don't think his sound is
And
working.
start with generalized
No,
anxiety
I don't
disorder.
think
Again,
so.
just a quick check. If somebody could unmute to confirm that they can see this.
I don't think you can hear us, Anthony. Jan
No.
was talking.
Yeah, he's not answering.
Well, I'll text him.
Yeah.
Sounds like we're having some audio difficulty. Can anybody hear me?
Yes, but you can hear
Can't
us,
hear us.
right?
How about now? Is the audio back on?
Can you hear now?
I can hear now, yes. Sorry
Okay,
about that.
good,
Yeah.
good.
So, sorry about some difficulty with the audio here. All right, so I take it back. I will
So
then
Jan
go
had
back to the
started,
initial question.
Jan was talking when you were gonna share.
Please go ahead.
Yeah, hi. I was just saying that I haven't seen the movie since it first came out, and seeing it again, I remember why I was scared to watch it. It's so well done and so terrifying. And certainly you see the obsession that Quint had, and each of them had a story. And I'm not sure if I missed what Brody's backstory was. I know that at one point he sort of looked down when they were showing their scars to each other in the boat, and he sort of looked at his chest a little bit and didn't say anything. And I just wonder, what did I miss?
Yeah, no, you didn't miss anything.
Oh.
That is a very subtle, fleeting scene that would cue the clinician into the fact that he too has a story. And what is initially presented as a specific phobia is likely much more extensive. Because when you recognize that first Quint with the USS Indianapolis tragedy, then Hooper, who had his quote, "Thresher eaten by a boat," end quote, Brody too seems to have had an interaction with a shark. And now the picture becomes clear as to why he has avoidance behavior, that it may not be a specific phobia. It may actually be post-traumatic stress disorder. And that's where this movie really turns, is that once you begin to think this through, it looks like all three men have PTSD.
Mm.
And what's remarkable is that it reminds us that the DSM and the American Psychiatric Association can take significant efforts towards categorizing and defining different illnesses. But the fact of the matter is that these conditions are behaviors, and behaviors are incredibly unique to different individuals. And a little later on, and really tying up our discussion later this afternoon, we're going to deconstruct these main characters and show the different phenotypic expressions or manifestations of this single illness called post-traumatic stress disorder.
There was one thing that I noticed that I just wanted to say about learned behavior, because when, was it Brody was with his son, and his son, of course, took the sip of whatever, and then he crushed did he crush it? Then he was praying, and then he was imitating his hand movements, putting his hands over. So, and that's certainly learned behavior. And so we can also learn anxiety through that behavior.
Yeah, I mean, I think in a vacuum, what Michael is demonstrating there is called echopraxia, Simon says. And echopraxia in a clinical setting may be indicative of frontal lobe pathology. Now, as a child, there's nothing going on here than him playing with his dad. But it does give a cue and therefore a prompt to discuss this clinical finding of echopraxia. And in a clinical setting, not around the dinner table, but a clinical setting, echopraxia may be indicative of frontal lobe pathology. And one of the conditions that you may consider is catatonia. Catatonia. Now, I thought that's interesting because, you know, I'm sorry, it wasn't Michael, it was the younger boy, demonstrating echopraxia, therefore demonstrating one sign of catatonia. And what happens later in the movie, his big brother, Michael, actually is catatonic as a result of his having been attacked by the shark. So it's a very interesting connection through the clinical terminology, specifically of echopraxia and perhaps catatonia. Any other observations or points taken from watching the film Jaws?
Hi, this is Kelly. Can you hear me? The thing that I think is so brilliant about this movie, and this really happened by accident because I've seen a documentary on it, is how little they show the shark in the beginning. And it's really because there were mechanical issues with this big shark that they called Bruce, but it really made the film that much more ominous because it was just music and like close cuts of water, but you don't really see what's happening, but you know something's out there, which I think really, for me, kind of really defines anxiety. Like, you know, something's out there that could potentially harm you, and it harms some people, and maybe it can harm you, but you can't always see it. So I think that's like what the genius part of this movie is, and why it was so successful, is because you don't really see the shark all that often, but you know it's there, and it's affecting some people but not others, and it's really causing this like mass hysteria and panic. And it draws for me some parallels to COVID, and of course COVID is a whole different thing, but it's just, you know, how it impacts people with anxiety disorders, where you know that there's something out there that's really tangible, but you don't know if you're going to get it, how it's going to affect you, kind of like the shark. It's there, but you don't know if it's going to get you or how it's going to affect you or what's the outcome is going to be. So I thought it was like it's one of my ultimate favorite movies. I saw it as a very young child. It came out the summer that I was born, and I saw it like when I was like maybe 5. I've always been a little phobic around water because I saw it as a young kid and it made such an impact on me. And I'm not a great swimmer, but I always think about it, and I like to go in the ocean, but I always think about it when I'm in the water. So that really made an impact on me, that movie.
Yeah, completely agree. 100% agree. In our medical school didactics, I will often present the shark fin as a new metaphor to replace the iceberg for anxiety. You see the shark fin, you see the tip of what is dangerous. Iceberg metaphor per Freud. You see the tip of the iceberg. Everybody will tell you that it's what's below the surface is what's dangerous, hence a metaphor for anxiety. Well, the same thing pertaining to a shark and therefore a dorsal fin. To my knowledge, nobody has ever died from a dorsal fin. The few shark attacks that we've had, the result is, well, in terms of the imminent danger, the actual jaws. So nobody's ever died from a dorsal fin attack. So a wonderful metaphor for anxiety. We're going to get to a little bit more of this too, because the shark in this film does take one step further. What I just described, that dorsal fin substituting for the iceberg and the iceberg metaphor, is a psychological theory of anxiety. Well, the shark, especially the great white, also serves as an animal model for the biological etiology of what is anxiety. And we're going to get to that in just a little bit. One other comment regarding Kelly's remarks. Again, something I'm in a complete agreement with. The mechanical shark malfunctions, and as a result, what we saw today is significantly different from the way it was written up. Spielberg had to pivot and change things drastically. And it isn't unlike a I believe it was an early 1970s horror film called The Earth Dies Screaming. And in The Earth Dies Screaming, the production goes significantly over budget, and very quickly they have to focus in on the human dynamic because they can't shoot on location anymore. And as a result, this movie is, or turns out to be, something that is much more humanly defined, human-centric than originally proposed. And George A. Romero watches this movie, and by that mere motif is inspired to write The Night of the Living Dead. And from that point on, if you did a count from 1968 on and looked at every single horror movie, I know this is true because I attended a seminar on this. If you took a body count of all the people that died in zombie-related genre, humans come out on top in terms of the number one killer. Zombies rank second. So the human element is what is to be clinical focused upon. That is the object of clinical focus in zombie films. And boy, does Jaws make the same very, very resounding statement. You put three men in close quarters, just like those people in close quarters in that farmhouse in Pennsylvania for Night of the Living Dead. You introduce an external stressor. In the Night of the Living Dead, they called it a zombie. Certainly in Jaws, it's the Great White, and you focus on the human dynamic. So there is a wonderful parallel between this film and almost every single zombie film ever made since 1968. And its focus on the human dynamic, which allows me to always use the tagline that Jaws has nothing to do with a shark. It has everything to do with the human element, and specifically post-traumatic stress disorder that is observed in those humans, those characters in the film. All right, we'll screen share now. We'll get to our PowerPoints. We're picking up with generalized anxiety disorder. And I think one of the main points I want to make here, the main point I want you to take from this slide, which was posted in our objectives slide, is that this condition has specific DSM criteria. And to remember what those actual criteria are, I'd like you just to think that generalized anxiety disorder, or GAD, is a merging of two conditions, one of which is major depressive disorder, or MDD, and the other is excessive anxiety or worry. What you're looking at here, the DSM criteria of a major depressive episode, and therefore the core principle to major depressive disorder, often remembered by the acronym SIGI-CAPS. If we removed the letters, you can see that there is significant overlap with generalized anxiety disorder, including impairment in energy, concentration. There is psychomotor agitation, as well as sleep disturbance. If we're going to stick with the same acronym, SI does not stand for suicidal ideation. It instead stands for significant irritability. G does not stand for guilt, as it does in MDD. It instead stands for generalized muscle tension. And then finally, A does not stand for appetite, as it does in major depressive disorder, but instead represents anxiety and excessive worry. And I bulleted anxiety and excessive worry different, just so you're reminded that it is the core principle that allows one to define generalized anxiety disorder. So in summary, if someone presents looking depressed, but also endorses clinically significant anxiety and worry, the most likely diagnosis is going to be generalized anxiety disorder. You are now looking at the actual DSM criteria. Rule out general medical illness. Medical illnesses present in one of two ways. they present in the traditional sense with physical signs, or they may present in a non-traditional sense through behavioral signs. When an underlying medical condition presents non-traditionally through behavioral signs, that manifestation, and for purposes of today's lecture, for example, anxiety, is deemed an anxiety disorder due to a general medical illness. That is, there is something physiologic about the cancer, about the anemia, about the infection, etc., that instead of presenting physically is resulting in a chemical imbalance, and instead presenting behaviorally. And anxiety is one of those behavioral signs that an underlying medical condition may manifest as. To look at this clinically, one of the questions that clinicians struggle with is whether or not there is evidence, in this case a film, of a medical condition in the main character. And often the answer is no, because producers don't necessarily think in these terms. And then the follow-up question is, does then the absence of information reassure you that therefore is no general medical illness inducing their mental illness? That is, does the absence of it in the script reassure you that therefore it doesn't exist? And that answer depends. It may be yes, maybe no, and might be not sure, depending on other variables. And I'll give you an example. Usually in clinical practice, female sex and young age confer a protective nature when it comes to medical conditions. People who are 88 are simply sicker than those who are 8 or 18. The opposite is also true. Male sex and older age are risk factors for medical illnesses. So if your patient is devoid or absent of those two major risk factors, we'll call that a negative, then you probably will be reassured. On the other hand, if you skip down to that last bullet, if the answer is no, it's likely because they have both male sex and are of older age. They're a plus plus. Of course, if you are mismatched, then you're an intermediate risk. So we're not going to really be sure one way or the other whether or not the absence of medical signs, the absence of it actually being written in the script reassures the clinician. That would be the intermediate maybe. These are some of the conditions. The list is going to be exhaustive, but these are some of the more common conditions that might present anxious. The acronym here is physical diseases that have commonly presented anxious. PD, TH, CPA. And I'm going to just give you the list here. I'm not going to go into these illnesses in any further depth or detail. And I apologize for not including the reference, but this is coming directly from a medical text. Starting with pheochromocytoma, that is an endocrine tumor, all the way to an arrhythmia, that is an abnormal rhythm of the heart. Just a quick filler for those who have watched Cloverfield. And again, if you haven't, it's time to put that in your short list. We actually see some pics of what looks like parasites named human scale parasites, or HSPs. The bite of the HSP is venomous. It infects its victim with a substance that causes bleeding, hemorrhaging. That substance is called seabed's nectar, and cleaning the wounds with water actually accelerates the infection, and you can actually see Marlena's unfortunate demise on the right. So here. So when we look at this monster and understand that it has these parasites all over him, might his behavior be something in addition to separation anxiety disorder, or given the monster's age, it is only a baby, separation anxiety. And the answer is that we could not or would not definitively rule out that Clover's, the monster's anxious behavior isn't due to the direct and physiologic effects of the HSPs. Hence, we might stick it under H in that same acronym. If your patient presents to you with clinically significant anxiety and does not neatly fit in to any of the categories I presented to date, one of the considerations at this time would be to diagnose with either other versus unspecified anxiety disorder under the rubric of etc. Again, no further detail on really what differentiates other from unspecified. It's primarily a coding issue, billing issue, and therefore really out of context for today's seminar. And then that brings us to really focus on the case study of JAWS within the context of the trauma and stressor-related disorders. If the obsessive compulsive and related disorders are before, trauma and stressor-related disorders fit the acronym of AFTER, A-F-T-E-R. And we begin, again, you could follow bottom left, lighting up from left to right, the word after. A represents adjustment disorders. This is a cause and effect analysis. Individuals present with anxiety because of a trigger. The treatment planning then would be to observe over time, because unless the trigger is persistent, unless the precipitant is persistent, the reaction is likely to self-terminate. So again, this is cause and effect, which as per the APA means that the onset of anxiety will be within 3 months of an identified stressor. And once the acute stressor terminates, that anxiety will not persist for 6 additional months. That is, within 6 months, it will self-terminate. Now, in clinical practice, this may get a little complicated because not all stressors are acute. Some are persisting. And the bottom line is, yes or no, does that allow us to still render a diagnosis of adjustment disorder? And there's no simple answer to that. Unfortunately, there isn't. So to date, the APA has stuck with this definition, despite the fact that in the real world, many stressors that impact individuals' functioning are persisting and not acute. We're talking about anxiety today, and therefore we used adjustment disorder with anxiety as an example, but there are multiple adjustment disorders. An adjustment to a trigger, to a precipitant, can also result in depressed mood. It can result in mixed anxiety and depression, so both of the above. It could result in a disturbance of conduct, and then all of the above, which is that there is not only disturbance of conduct, but also emotions, either depression or anxiety as well. And if not any of the above, of course, we have the unspecified category as a grab bag. We do know that upon separating from its mother, we see anxiety in Clover, again, upper right-hand corner, but there's also, and anybody who's watched this movie, I don't think would be able to argue that we also observe a significant disturbance in conduct as well. The letters FT in the acronym AFTER stand for following trauma. And there are 2 conditions that can follow trauma: acute stress disorder and post-traumatic stress disorder. In each case, the individual's history would include exposure to actual or threatened death. As a result, the individual engages in avoidance behavior. Avoidance may be to things internal as well as external. Now, I think in clinical practice, we are very adept in identifying avoidance behaviors to external reminders. Clinicians are not as adept in identifying avoidance to internal stimuli such as memories, thoughts, and feelings. Once you establish this, the acronym is STOP, he is afraid. And this acronym actually conforms quite well to the different subsets of symptoms, the first of which are the inclusion criteria that are defined through the acronym STOP. One comment, you're going to have to give me a mulligan here. The letter O stands for other, so it's a cop-out. But the good news is that I think most people automatically think of nightmares and flashbacks as examples of PTSD. So when you come to this category of other and it appears that this is a little bit more difficult to remember, the fact is that it will stand for, that is, other represents those signs and symptoms that I think are intuitive to most people when considering or discussing PTSD. He is are the arousal criteria: hypervigilance, exaggerated startle, irritability, as well as impaired concentration, sleep disturbance, as well as self-destructive behavior. A couple of comments about self-destructive behavior. Number one, if you chose a movie in which the protagonist is a female, you can easily take self-destructive behavior and flip it to the top of this slide and change the acronym to STOP, she is afraid. So it fits irrespective of what movie you choose. The other comment I want to make about self-destructive behavior is that up to 50% of individuals with this condition have a comorbid alcohol use disorder. And boy, isn't that what Martin Brody demonstrates? The final criteria set is labeled cognitions and mood, and afraid details those diagnostic criteria. One comment, this criteria set does include exaggerated negative beliefs. I keep that in parentheses just because it doesn't fit with the word afraid, but included on this slide, at the bottom of the slide, nonetheless. There are specifiers that are new to the DSM-5, detailing or defining post-traumatic stress disorder. Individuals may have dissociative feelings and they could have delayed expression. The dissociative feelings or symptoms can include, as an example, depersonalization as well as derealization. Depersonalization basically is the subjective sense that one's self is unreal or detached in some way. More detail provided on this slide for you. And whereas depersonalization focuses on self, derealization focuses on other, specifically your immediate surroundings. Specifically, the individual has the subjective sense that their immediate surroundings are unreal or detached in some way. Depersonalization, the out-of-body experience. If anybody here has ever had an out-of-body experience, number one, I think it's fairly easy to then recognize the definition of depersonalization. And number two, I can reassure you, you are not mentally ill. If those episodes, if you're having had an out-of-body experience become recurrent and clinically significant, then you might have a mental disorder. But if you ever experience this and nothing untoward resulted from it, we're going to fall significantly short of calling it a mental disorder. Derealization, I think an easy example would be deja vu. Many people experience deja vu. Only when deja vu is recurrent and clinically significant might it be part of a larger disorder such as post-traumatic stress disorder. So adult pathology results when one is cued and re-experiences. And this now will focus a little bit on neurophysiology, specifically a gland in the brain called the hypothalamus. The hypothalamus is the gland in the central nervous system that is responsible for the fight or flight response. And that's been expanded to the fight, flight, or freeze response. This theory or is there a question? Oh, okay, I'm sorry. This theory has been expanded to include 4 defensive responses. And I want to focus your attention on the last one, which is tonic immobility. If you look at 2, 3, and 4, it's exactly coming from the previous slide, right? Fight, flight. But when an individual is not awarded or given either of those options, freeze might be the result. And this goes by different names. In clinical practice, we refer to freeze or the freeze response as dissociation. But in animal behavior models, we call it tonic immobilization. So again, while those first 3 responses have actually been extensively studied in humans, tonic immobility has only been investigated in animal models. And one of the more common animals studied are sharks. What happens here is that the shark, when turned over on its dorsum, goes into a state of freeze. They dissociate. They are demonstrating tonic immobility. And they will stay in that state for a while. As the shark is in that state of tonic immobility for 20 or so minutes, pods of killer whales and other predators can prey upon them. So this phenomenon is a limbic system function, hypothalamic function, that serves as an animal model for dissociative-like symptoms experienced in multiple mental disorders, including the trauma and stressor-related disorders. If we remember that scene where Michael is in the water, looking at his face, we can see that he is not fighting and he is not in flight. He is freeze. He is dissociating. He is in his own state of tonic immobility. We also know when he's actually brought to land that there's another term that is commonly used to describe this, albeit out of clinical circles, and that is he's in shock. So all those terms are interchangeably. Dissociation is the one that is clinically applied. All of the above applies to those illnesses, quote unquote, following trauma. How to differentiate acute stress from post-traumatic stress disorder is a timeline. And 1 month is that magic number. If these signs and symptoms are clinically significant but are not 30 days, acute stress disorder is the most likely answer. On the other hand, if those signs and symptoms have expanded beyond 30 days, then post-traumatic stress disorder is the likely diagnosis. E stands for engagement or engagement disorder. The full name is disinhibited social engagement disorder. Trust me, abbreviating it, remembering it as engagement disorder works just fine. This condition is defined when an individual, usually a child, actively approaches and interacts with unfamiliar adults. And then you could see the rest of the criteria in bullets 3 through 6, right? So this is not, or this behavior is not due to a larger disorder. Easy example would be ADHD. The etiology is thought to be insufficient care, and it may be persistent. The R in the acronym, and it's nice that these two are juxtaposed as well, the E and the R, reactive attachment disorder, is the opposite, in which the individual, the child, demonstrates inhibited and emotionally withdrawn behavior. So the direct opposite of actively approaching strangers is being inhibited around familiar figures. again, the child is between 9 months and 5 years. It cannot be due to a larger disorder. The example here is an autism spectrum disorder. The etiology, again, is thought to be insufficient care, and it too may be persistent. And if you look at a dual slide, engagement, reactive attachment, you can see how they match up quite easily. The ages are about the same. The main idea that either cannot be attributed to a larger disorder is the same. And then that third bullet really is what differentiates. In one case, they are actively interacting with unfamiliar, and in the other case, they're doing the exact opposite, even with familiar. And then the next two bullets are exactly the same for each condition. So that's engagement versus reactive attachment. All right, so I'm going to take a brief breath. We're now in our final half hour, and ask if anybody has any questions.
Oh, I had a question about Brody. I was just wondering, can you hear me?
Perfect, yeah.
Oh, good, okay. Yeah, so it's kind of like there's a happy ending in that the good characters survive, and Brody rises to the occasion, and he's got this phobia, but yet he's the hero. He's climbing on a boat, he's getting a gun, he's shooting a shark. You know, and I'm wondering, is that realistic in terms of these kinds of phobias? Because it seems a little, well, I mean, it's unrealistic as a movie, but just in terms of the phobia part.
So in one context, no. That is, I would never expect to put any of that on the shoulders of my patient, and I would be loath to even consider putting it into a treatment plan. However, having said that, I do want to slant this towards a teaching perspective, and that is, number one, clinically, someone with PTSD, when put in a situation in which their hypothalamus may need to fight, flight, or freeze, might fight, even though the first 30 plus years of their life, they have chosen subconsciously freeze. So could that happen? Yeah. Are the bets that they're going to engage in the same defense that they've engaged in for years prior? Yeah. I mean, the best prediction of future behavior is prior or past behavior. Having said that, it could happen. All right. So, and that's what happens here. Brody reacted the way he did when he was bit on the right side of his abdomen when he was a child. And he reacted in a dissociated or freeze state. When given, we'll call it a second chance, we'll keep it fictional. Years later, decades later, his hypothalamus simply doesn't resort to freeze again, but instead fights. Again, good story. Is how meaningful is it, and is that likely to happen? It could happen, but it would be just as, I think, clinically consistent if he froze again. But nonetheless, it could happen. It definitely could.
Dr. T, I'm thinking about the fact that there's a comment made about, why he even took that position. I know that he references things are so tough in New York City now, you can't believe what a mess it is. But on the other hand, with a phobia or any avoidance of those issues, to take that position in what is just virtually a beach situation, I also wonder about that too, in terms of I'm not sure what reaction formation or whether just unconscious content or what the scoop is.
Yeah, that's a great question. I completely agree with you, and I would love to write the prequel to Jaws and actually see the detective Brody as NYPD and what was going on there. That is, there may have been some apprehension of taking this job on Amity Island, but again, this is where my questioning and inquiry would go. There was probably more of a push to leave Manhattan than there was apprehension of going to Amity Island. And my question as a psychiatrist would be why? What was happening as part of NYPD that was interpreted in such a way that this was your better option. I think throughout most of this movie, we identify that through the defense mechanism of displacement and then avoidance, Martin Brody's phobic avoidance is pretty textbook. A little complicated because he does choose to take this position, but nonetheless fairly textbook, and allows us, as we have, to discuss defense mechanisms such as displacement and avoidance. Avoidance being a defense mechanism that directly translates to avoidance behavior. Nonetheless, as straightforward as that might appear on the surface, a little bit of a deeper dive suggests that his phobic avoidance is actually due to PTSD, and this particular scene, I believe, is what uncovers just that. There is a scar in his right lower abdomen that he reveals he is going to enter into these war stories, then decides not to share. So, very complicated character with co-occurring alcohol use disorder. He is clearly using alcohol not only in excess, but during situations within which it is likely to be physically hazardous. How about Quint? Well, this is just the copy and paste of our previous slide, comparing Ahab to Quint, but there's a little bit more to it than that. Well, whereas Brody's behavior is primarily textbook avoidance, that's not the case for Quint. He is not avoiding the ocean. Matter of fact, he's made a career on the ocean as a fisherman. This is likely a product of defense mechanisms that are traditional in describing and defining phobia and phobic avoidance, switching over to include denial and reaction formation. So we see a character, we see Quint do the exact opposite of what we would have predicted. Instead of avoiding the ocean, he is on the ocean. And that's how he makes his living. Denial or reaction formation, two defense mechanisms when they are substituted for avoidance, explain what is referred to as counter-phobic attitude. Again, the observation that one runs towards their fear instead of away from it. And I think all of the above is hinted at and then well defined, described, and explained through this scene. What do you say?
Trophies of everything he's caught.
Frightening trophies. Trophies
right.
of the jaws, the monstrous part of the shark.
And I think knowing what we now know, this appears to be a product of A, reaction formation, and therefore B, counterphobic attitude. This is a direct product of that. But is there more? So let's talk about this. There's another defense mechanism that I believe is in play for Captain Quint. And it's a defense mechanism that we previously described and discussed called undoing, right? So that's in a previous slide, and we had discussed that, albeit in the context of obsessive compulsive disorder, which was the provisional diagnosis we were considering for Quint. Those jaw bones represent undoing. Something happened to this captain that resulted in his belief that if he killed enough sharks, he would be able to undo what happened to him on the USS Indianapolis. And once you understand that, you you really begin to understand what this film is really about. Does anybody have any questions about that? And I think one of the lines, one of the scenes that supports this very notion is that clearly Quint is still sick. His anxiety, survivor's guilt, I could say it, has not been addressed despite his killing all those sharks with all those trophies. That is, quantity simply has not solved this problem. Hence, why Jaws was written. Because Jaws is about a 25-foot great white. So where quantity didn't complete the task, quality will. And we see this when that shark is first spotted on the orca. And I believe it's Hooper that yells out, must be a 20-footer. The next line comes from Quint's lips, 25 at least. You know why? Because it has to be. If this isn't the biggest shark ever, and if he doesn't kill the biggest trophy ever, he does not undo the death of his 300 comrades that went down in the mid-Atlantic that day. So undoing first through quantity, but as the movie Jaws depicts, then through quality.
Do you think, oh, sorry. Do you think that when Quint and Hooper were doing the one-upmanship, who got the worst injuries, was similar to that?
It's a good question. Yeah, I know exactly what you mean. So you're where we have to actually watch and pay attention, look for those trophies for Quint. Is Hooper not telling us verbally the same thing? I don't know. I will tell you what I really think, what I believe makes Hooper tick in just a second. I have to think through whether or not some of the same dynamic as we've identified in Quint also translates to Hooper's behavior. That's a good point, though.
I got a question, Doc, quick. Do you often see counterphobic attitude clinically, or I mean, is it often?
No, and I can tell you that when we do see it, I believe it is underrepresented and is underdiagnosed, because what would happen is that individuals are engaging in high-risk behaviors, and a lot of those behaviors have become mainstreamed, right? So like X Games, which was a decade plus ago, extreme sports, all of these are outlets. And because they appear to be functional outlets, people are going pro, etc. It's very difficult to identify and tease out pathological behavior from behaviors that a culture is beginning to reward. So as a result, I don't see much of this at all. Does that make sense?
Yes, thank you.
Yeah, but make sure I answer the question quickly. Yeah. And this is my favorite dialogue of the entire movie, right? I want to bring your attention to that fourth line, and specifically the second sentence in that fourth line, seen here. Okay. What does Ellen mean here?
What happens if he dies? I'm assuming.
Yeah, I mean, again, he was NYPD. He's been sheriff. Especially his older child, Michael, has known what it's like in terms of what risks, what's part of the job for Dad. So when he's going out fishing or sharking, this should not be a question that a mother needs to ask her husband. She having to have dealt with this her entire life, ever since having her oldest son. What she instead is asking, what am I going to tell the kids, is how do I explain your demise, not from the shark, but through Quint's actions? And that's where we get to this update, and I'm sorry I had to go back, but now we can add, given all of that which we just discussed for Captain Quint, another aspect of the MSC, killer endings. Again, ABC stamp liquor, the KE lighting up on your bottom left. Quint never planned to return from this voyage. And he has no regard for the welfare of anybody on that boat. I think there's some semblance of that when they first charter the vessel. He doesn't want Brody to come. He's overruled. He certainly doesn't want Hooper with him. But once they're on the boat, I think his reaction is, you know what? They made their own bed. I tried. He never intended to come back. And there's several instances in which this is actually supported. We know he destroys the radio. He cuts off communication with the mainland.
But there's also some ambivalence, I think, don't you? I think I totally agree that this was going to be his journey, and knowing that this is the way he, in his own mind, probably should die. But then you see those little pieces, which I think might have been reminiscent to his lamentation about the men that he was friends with, who died, when he just says, you know, next time I'll do it, chief, or, you know, watch your hands. When you do this, it'll cut your hand off, or, you know, so he has these little moments, I think, of affiliation with them, which reminded me of how much he cared about the people that he was with in, you know, in the initial trauma that he went through. But then he's just, you know, as you said, smashing the radio and going for broke. But there were those little moments where he was associated, you know, with them, I think.
I completely agree. In his final moments, and again, he knew of his demise. He's reflecting back. Yep. And in this scene follows when he mentions that he'll never wear a life jacket again. Of course, when the ship is flooding, he passes them, and you could see him just glance to his left, and there is a resolution that he is not going to put that life jacket on, that he is going to go down with the ship.
There's also a moment when Brody is in freeze response and Quint has to remind him to put out the fire in the interior of the boat. And he just kind of sitting there staring, and he goes, hey, put that fire out, will you? So interesting as a firefighter that he froze in that moment and couldn't like attend to that fire. He had to be reminded.
Yeah, and how about Quint's affect? I mean, inappropriate, blunted, and restricted. I mean, you know, there's a fire. Usually when there's a fire, there's a little bit more emotion. In his tone, his affect is as a matter of fact, as somebody on the beach saying, why don't you put your seat under the umbrella? The sun's getting hot. I mean, that's how distant he was emotionally from what was going on at that point. The final character, and I saved this one for last because this is one that I think comes out of the blue. Some people might actually get to the suicidal tendency of Quint, but little see what is on the horizon for Matt Hooper. First and foremost, he is the third protagonist in this film that is afflicted with PTSD, and here's the actual script attesting to that. And this is the actual scene. And this is the same exact kind of dynamic in that we start with the textbook framework of a phobia or phobic avoidance within the context of PTSD, but replacing avoidance behavior with sublimation results in his being part of the Oceanic Institute instead of avoiding the water. So sublimation is the creative expression of that internal conflict. That internal conflict, as a result of that thresher eating his boat, becomes manifest through something productive and artistic, like a career at the Institute. And that's that process, that ego defense, is called sublimation. But there's more to it than that. When Ellen realizes that Quint is suicidal, she tries to convince her husband not to go on that boat. We see it, it's behind the scenes. I'm sorry, we don't see it, it's behind the scenes. And as the end of that dialogue, because we do begin to uncover that conversation in its final moments when they reach the dock, she asks, what am I going to tell the kids? My belief is that Brody, given his career in NYPD, really believes that he can change Quint's mind, that he's there to serve and protect, and that it's part of his job now as sheriff to be on that vessel. And he even says, yeah, it's your boat, but it's my charter. So there's this degree of responsibility. And that might explain why he would get on a boat that is destined to be a suicide mission. Hooper doesn't have that going for him. That doesn't explain, or we're really kind of handcuffed to explain why Hooper gets on that boat. And I think first and foremost is because he doesn't recognize the imminent danger that lies ahead of him. And the reason why begins with this dialogue. This is first, I believe, manifest when he is introduced to Quint in that cabin, and Quint grabs his wrists and says, show me your hands. Right there, number one, we know that Hooper comes from money. If you then remember the discussion he has with Brody, searching for Ben Gardner's boat, Brody identifying the equipment and asking if the Institute purchased this for him. Not only does Hooper provide the information attesting to his level of wealth, but if you watch closely, his affect suggests that he is actually embarrassed of it. And when you recognize that, you then have a reason, you have an understanding as to why this seasoned veteran missed the captain of the boat being suicidal. And finally, this scene again reinforces why. And that is his difficulty with authority figures, likely the result of his relationship dating back to his father. When Quint takes on that fatherly or paternal role, literally, this grown-up is making those childish faces behind his back. And it's because Hooper is so wrapped up with his own baggage and his own father issues and his own childhood experiences that he misses what is right in front of him, and that is a suicide voyage. And again, this is the conversation that really wraps it up on the Aurora, or pertaining to the Aurora, which I think is very interesting. Although the primary interest is because it links directly to another movie, The Thing, which is about anxiety as well, which is an alien film similar to Cloverfield as well. But obviously the discussion of which is beyond the context of today's seminar. We are right up to 3 o'clock. I'm going to end it here. Like I said, as by design, I included all those extra slides relating to other movies, starting with The Thing. That's for your viewing. If you have any questions, I would strongly encourage you to reach out to me. I'd be more than happy to discuss aspects of The Thing or any of the other movies that are contained in the remaining slides. But for now, I will stop sharing my screen and ask if anybody has any questions.
Thank you.
If nobody has any questions, I'll ask either Ricky or Noel to join us, and if they have any final announcements. They might be juggling other things.
Muted.
Thank you so much, Anthony. We appreciate you and all you've done with us over the years.